How many agents are you aware of that have been delivered clinically to patients for more than 200 years and in continuous clinical use for more than 175 for the same purposes? Nitrous oxide is one of them. It's the first anesthesia gas, and right now it's the only anesthesia gas, and you need to know about it. Fundamentals of Anesthesiology with me, Pat Nelligan. Understanding gases and vapors. This tutorial is on the first and the currently only available anesthetic gas, nitrous oxide. In the previous tutorials, we looked at emergence from volatile anesthesia. We talked about the concentration flow ramp, duration of surgery, body habitus, the impact of hypothermia, hysteresis, and other drugs. And we also talked about emergence from anesthesia associated with spontaneous breathing versus intermittent positive pressure ventilation. In this tutorial, we're going to look at nitrous oxide. First, its properties. Second, concentration effect, second gas effect, and reverse second gas effect. And then we'll move on to talk about the max sparing effect and the complications and benefits of using nitrous oxide. Nitrous oxide is a gas and it's made up of two atoms of nitrogen and one of oxygen. It was originally prepared by Joseph Priestley in the 18th century and it was used recreationally for several decades until Horace Wells first used it in dental surgery in 1844. The case was a disaster and the patient shouted out in pain, demonstrating that nitrous oxide is a poor primary anesthetic agent and it was rapidly supplanted by ether. Nevertheless, it's had a long life in anesthesia practice. It's a gas, it's not a vapor, and its boiling point is minus 88.5 degrees Celsius. So it is always a gas, but it can be compressed into a liquid under pressure. The critical temperature is 36.5 degrees Celsius, which means that it can be stored in cylinders as liquid if kept indoors and I suppose outdoors in temperate climates. There are very few places in the world that you can be sure that the temperature outdoors will stay below 36.5 degrees Celsius. The key thing to understand is that nitrous oxide in and of itself cannot deliver anesthesia. It has sedative and analgesic effects, but cannot deliver sufficient hypnosis, amnesia, and immobility to be considered a general anesthetic agent. The MAC is 104%. It's usually combined with volatile agents like sevoflurane or halothane or propofol for anesthesia, or it's combined with oxygen in a 50-50 ratio to provide analgesia. This is Entonox that's used on the labor ward. It has some significant advantages. It has a rapid onset and offset of action. It can be used as an analgesic and anxiolytic. It has minimal impact in the cardiovascular and respiratory systems. It reduces intraoperative analgesia requirements. It may or may not reduce chronic post-surgical pain, and it's widely available and very inexpensive. Its current use is on the labor ward, as I've mentioned. It's also used in dental offices to provide what they call anesthesia, but it's really sedation. And in anesthesiology, it's used to speed up the action of volatile agents during inhalational induction, to speed up the FA-FI following IV induction so that you have a smooth transition, to minimize the dose of volatile agent used during maintenance, and to speed up the offset time of volatile agents during emergence. The reason why nitrous oxide is used in these settings is because of its relatively low blood and tissue solubility and the fact that it replaces nitrogen in fresh gas flow. These unique characteristics underpin three fascinating physiologic phenomena that have shaped our understanding of inhalational anesthesia. The first is the concentration effect. The onset and speed of action of anesthetic agents relates to the speed at which the FA divided by FI approaches 1. When a mixture of gases is delivered to the alveoli, for example, oxygen and nitrous oxide, the most soluble gas will leave the alveolus faster. That's nitrous oxide. And the size of the alveolus will fall. Nitrous oxide is 100 times more soluble in blood than oxygen. The concentration of the remaining gases will be higher. Let me illustrate this. In this scenario, we are delivering 70% nitrous oxide to our patient. Because nitrous oxide is more soluble than oxygen or nitrogen and it is given in large quantities, there is rapid uptake into the blood, causing the alveolus to shrink. Once the alveolus has shrunk, the concentration of the gas that remains in it increases, the concentration effect. That results in a higher partial pressure gradient between the alveolus and the blood, and there is a relative increase in the uptake of the agent into the blood as a consequence. As this corresponds to higher delivery of the agent, in this case nitrous oxide, to the brain, the onset of action, the FA-FI, is more rapid. This effect can be used elegantly to speed up the onset of action of volatile anesthetics during inhalational induction of anesthesia. In this situation, we are administering a mixture of 70% nitrous oxide and 30% oxygen, and into that we are delivering 4% sevoflurane. Because nitrous oxide is administered in high concentrations, that's 50 to 70%, its rapid uptake removes a large volume of gas from the alveolus. As the alveolus shrinks, the remaining sevoflurane becomes more concentrated, increasing its alveolar partial pressure and driving faster uptake into the blood and ultimately to the brain. This is known as the second gas effect. In practice, this is how many anesthesiologists perform inhalational induction. First, the patient breathes 50% nitrous and 50% oxygen. This is the concentration effect. Then sevoflurane is gradually introduced, the second gas effect. Eventually, you may administer 8% sevoflurane. At this stage, overpressure is driving the FA-FI. Many will actually discontinue nitrous at this stage in case they encounter airway difficulties, but many will just leave the nitrous oxide on and then reduce the volatile agent to keep the patient at the plane of anesthesia that is required. Now, the concentration effect and the second gas effect occur on induction of anesthesia. But what about emergence from anesthesia? Rapid uptake of nitrous oxide accelerates induction by concentrating the accompanying volatile agent. Conversely, at the end of the operation, rapid elimination of nitrous oxide dilutes the remaining volatile agent within the alveolus, accelerating its elimination from blood and brain and shortening emergence. This has been termed the reverse second gas effect. Many anesthesiologists have utilized the reverse second gas effect in practice. Nitrous oxide in this setting is administered to increase the speed of offset of anesthesia at the end of the case. Because nitrous oxide is significantly less soluble in tissue and indeed blood than sevoflurane or isoflurane, introducing nitrous towards the end of the case and turning down the inhaled sevo dose creates a tissue to blood gradient of sevoflurane plus a gradient between the blood and the alveolus, increasing tissue washout and reducing emergence time. Of course, this can be achieved by just reducing the sevoflurane alone. So why do you need nitrous oxide? The major reason that most anesthesiologists will say that they're using nitrous oxide is to reduce the risk of awareness during emergence from anesthesia when the sevoflurane, for example, is turned down. This ignores the impact, of course, of hysteresis, but also overrates the ability of nitrous oxide to prevent awareness, as we will shortly see. I previously discussed how MAC is additive when gases or vapors are mixed, and for the most part, this is true, but there is some nuance here. Remember, MAC is the exhaled concentration at which 50% of patients do not move to a surgical stimulus. That is principally a spinal cord effect. The assumption traditionally has been that if MAC is additive, then that should scale into the other effects of anesthesia, hypnosis, amnesia, and analgesia. However, in this study from 1992, it was demonstrated that yes, nitrous is MAC equivalent with volatile agents for movement, but it is less effective than an equivalent MAC fraction of volatile anesthetic at suppressing responsiveness and memory. If a patient receives 0.45 MAC of isoflurane, fewer than 10% of volunteers respond to verbal commands. At 0.45 MAC of ISO, conscious memory is lost. 0.45 MAC of nitrous oxide, all patients responded to verbal commands. At zero point 0.6 MAC of nitrous oxide, most still had conscious memory. So nitrous oxide is less than 50% as potent an amnestic and hypnotic agent than is usually claimed. I think most anesthesiologists fundamentally knew this. For example, this prior study from 1990 by Eager's group empirically omitted nitrous oxide during isoflurane anesthesia. And isoflurane requirements increased from 0.64% in 60% nitrous to 0.85% in an oxygen and air mixture, which is about zero point 0.7 of a MAC without a problem. I think this study demonstrated that the majority of anesthesiologists ran patients at higher isoflurane levels than anticipated, as using the same dose of nitrous should have reduced the ISO dose by about 58%, but doctors chose to estimate that effect at 25%, because presumably they were more concerned about recall and awareness at lower isoflurane levels. A similar phenomenon was observed in the Enigma trials. These were two international randomized controlled trials that looked at the use of nitrous oxide in contemporary clinical practice. In these trials, a lower fractional MAC target would have been anticipated with nitrous oxide. 70% nitrous contributes approximately 0.6 of a MAC. Anesthesiologists did not appear comfortable reducing the volatile concentration by that amount. In practice, most continue to maintain an age-adjusted volatile concentration of about 0.7 MAC or higher, suggesting an implicit recognition that nitrous oxide contributes more to immobility than to hypnosis or amnesia. Perhaps that is why most anesthesiologists instinctively treat nitrous oxide as an analgesic and MAC-sparing agent for movement rather than a true substitute for volatile anesthetic. Importantly, although many anesthesiologists believe that nitrous oxide reducing the volatile agent would result in earlier emergence and earlier discharge from recovery, that was not found to be the case in the Enigma 2 trial. One of the other arguments for using nitrous oxide in high concentration is cardiovascular stability, but no prospective randomized controlled trial has demonstrated outcome benefits from this purported hemodynamic stability of nitrous oxide. There is some cardiovascular data from the Enigma 2 trial, and although nitrous oxide is volatile sparing, Enigma 2 suggests that this does not confer a measurable cardiovascular advantage in contemporary balanced anesthesia. It is neither beneficial nor harmful. Operational issues. Nitrous oxide has been used for nearly 200 years, and traditional analog anesthetic machines had three flow meters for gas: oxygen, air, and nitrous oxide. Remember, air always contains 21% oxygen. There was a problem with flow meter controls. If there was damage to the oxygen or the air flow meter, it was possible to deliver a purely hypoxic mixture to the patient where the patient only got nitrous oxide. Patients died from this. Now, this cannot occur today due to locking mechanisms. But regardless, the delivery of a gas to a patient that may not contain oxygen remains a potential risk. Nitrous oxide may be delivered by pipeline to the operating room, usually derived from a battery of cylinders somewhere in the hospital, and a lot of the gas leaks out of these pipes. This adds complex equipment, piping, and costs to operating room construction, and it is not essential. Many newly constructed hospitals no longer pipe nitrous to their operating rooms, but you can give nitrous oxide via a cylinder that is connected to the back of the machine if, for example, you need it to deliver inhalational induction of anesthesia. Let's move on and look at the complications of using nitrous oxide. The first and probably the most important problem is associated with closed airspaces. Nitrous oxide diffuses into gas containing spaces much faster than nitrogen can leave them because it is more soluble than nitrogen. Nitrous oxide is 30 to 35 times more soluble in blood than nitrogen. When we're giving nitrous oxide, the inspired concentrations are high, usually 50 to 70%. A large partial pressure gradient exists between the blood and these gas spaces. Because nitrogen is so insoluble and it leaves those spaces slowly, nitrous oxide fills the spaces and either increases their size or increases the pressure within them. If this space can stretch, then volume increases. And this is what will happen with pneumothorax within the bowel. The bowel will expand due to the gas in the bowel. If there is an air embolism, then the bubbles are bigger. If there is intracranial air, pneumocephalus will increase, pulmonary bullae will increase. Indeed, a pneumothorax may substantially enlarge subsequently during anesthesia. In non-compliant spaces, pressure increases, and that is really problematic. For example, in the middle ear, in the eye after intraocular gas injection, into some intracranial spaces, into the cuff of the endotracheal tube, just increasing the pressure on the membrane of the trachea. When tympanic grafts are performed on the middle ear, the use of nitrous oxide may increase middle ear pressure and displace those grafts, causing a surgical complication. The classic teaching is as follows. Closed gas space exposed to high concentrations of nitrous may approximately double in volume within 30 to 60 minutes under some conditions. Now, that does depend on blood flow to the surrounding tissues, the compliance of that particular compartment, the starting volume, the inspired concentration, and the duration. Small, highly perfused spaces change fastest. At the end of anesthesia, pressure in these spaces falls rapidly. So, if you're anesthetizing a patient, for example, for bowel surgery, neurosurgery, ENT surgery, it's probably best to avoid nitrous oxide. However, if it's a very short case, 30 to 60 minutes, that probably has no impact on the space. Diffusion hypoxia. At the end of the operation, nitrous oxide is turned off. There is a reverse second gas effect. Nitrous rushes along the partial pressure gradient to where it is in low concentration, the alveoli. This has the impact of diluting alveolar gases, principally oxygen, but also carbon dioxide. If a low FiO2 is being administered, this may result in transient hypoxemia. It's known as diffusion hypoxia, and it was originally described in this paper in 1949. Nitrous oxide also dilutes the alveolar CO2. Since mixed venous CO2 has not changed, the venous to alveolar CO2 partial pressure increases. As a consequence, more CO2 diffuses from the blood into the alveolus. This increased elimination of CO2 lowers arterial PCO2 slightly. The fall in the PCO2 reduces central chemoreceptor stimulation, and this leads to a transient reduction in ventilatory drive, hypoventilation. I am not certain how clinically significant this is, but it is something you should know about. If you were to encounter diffusion hypoxemia and hypocarbia, it would be in situations where high inspired nitrous oxide concentration is being administered, more than 70%. These are long cases. There's usually abrupt discontinuation in spontaneous breathing patients where the patient is immediately transferred to room air. There's no supplemental oxygen. Obese patients, patients with limited pulmonary reserve, and it's easily prevented by giving patients supplemental oxygen at the end of the case. You administer high flow oxygen on emergence. This does not need to be 100% oxygen, but certainly 30% or more. And the patient should go out to the recovery room with supplemental oxygen. Supplemental oxygen blasts nitrous oxide from the alveoli and definitely prevents hypoxemia. One of the main reasons that I often hear people not using nitrous oxide is because they believe it is a really nasty chemical for causing post-op nausea and vomiting. And there is no question that the use of nitrous oxide increases the risk of post-op nausea and vomiting. About a 6% absolute risk increase over volatile agents alone. There's minimal risk if the surgery is less than an hour, and the relative risk increases by about 20% for every subsequent hour, with an absolute risk increase of 6 to 7%. However, in the Enigma 2 trial, the increased risk of post-op nausea and vomiting with nitrous oxide was largely abolished by routine antiemetic prophylaxis. This is using ondansetron and equivalent drugs. Once you give those drugs, the risk is completely curtailed. Bone marrow depression. Nitrous oxide has a negative impact on both bone marrow and neurological tissue. It oxidizes the cobalt in vitamin B12 and activates it by inactivating methionine synthase. This impairs DNA synthesis, and as a consequence, rapidly dividing marrow cells cannot replicate properly, and this results in macrocytic anemia, leukopenia, and thrombocytopenia. For the majority of people, bone marrow depression is an unlikely event during standard anesthesia unless the operation is very long, 6+ hours. There's pre existing B12 deficiency, patient has minimal B12 stores, or multiple anesthetics have been delivered over a short period of time with nitrous oxide. Where we do see a problem, though, is with chronic nitrous oxide abuse. And this is an emerging problem. There are a lot of people out there sucking on nitrous oxide balloons as a drug of recreation. Although we worry about megaloblastic anemia, neurological injury is a major concern in this population because methionine is needed to make a chemical known as SAM. And this is used in the construction of myelin, and it's involved in other methylation reactions in the nervous system. Chronic abuse may result in peripheral neuropathy, subacute combined degeneration of the cord, and dorsal column dysfunction. Nitrous oxide as a greenhouse gas. Nitrous oxide has 273 times the global warming potential as carbon dioxide. It also has a negative impact on the ozone layer. Medical sources of nitrous oxide are a vanishingly small part of global output of nitrous into the atmosphere each year. It is less than 1%. We do need to acknowledge the impact of nitrous oxide and other anesthetic agents. As anesthesiologists, we balance many competing priorities: efficacy, safety, recovery, cost, and environmental sustainability. None should be considered in isolation. Our responsibility is to integrate them thoughtfully, but our first duty is always to the patient in front of us. So, yes, nitrous oxide is a significant greenhouse gas. Our contribution isn't huge on a global scale, although there is a bit of whatabouts about this, but you should be aware of it and wonder, when you're giving a patient, is it truly necessary to deliver the anesthetic that you need for your particular patient? So, when you go through the problems associated with nitrous oxide, there are lots of reasons not to use it. It is inessential and it does make anesthesia more complex. There is the risk of the hypoxic mixture in a malfunctioning machine. It expands closed air spaces such as bowels and pneumothorax. It increases mildly the risk of post-op nausea and vomiting. There's no doubt that with prolonged use, there is a risk of bone marrow suppression. There is the risk of diffusion hypoxia at the end of the case, and it's a greenhouse gas. However, there are reasons why you might want to use it. It is very effective in inhalational induction of anesthesia. This is where the majority of my colleagues use nitrous oxide these days. It reduces MAC in patients where one might wish to limit the dose of volatile agents, but there is no evidence of lower risk of postoperative cognitive decline. It undoubtedly helps eliminate tissue bound volatile agents by substitution and the reverse second gas effect. And it will reduce movement in propofol only total IV anesthesia. And that's a movement MAC effect, not a hypnotic effect. So, do I think there's still a use for nitrous oxide? Absolutely. But again, this is up to you how you use this drug in your career with respect to your own patients. Let's review this tutorial. In this tutorial, we discuss nitrous oxide, the original anesthetic gas and currently the only anesthetic gas that we use in clinical practice, its properties, the concentration effect, the second gas effect, the reverse second gas effect, the max sparing effect, and the complications and benefits of using nitrous oxide. Next time, we're going to look at volatile anesthetic agents and their pharmacology: isoflurane, sevoflurane, and desflurane. I'll see you then, and I guarantee you'll learn something.